Hi, my name is Simone Lysaght. I'm the Clinical Nurse Manager in the National Rehabilitation Hospital in Nursing Documentation. My main project was digitising the Daily Operational Safety Huddle. So just a bit of background information around the Daily Operational Safety Huddles. They were first introduced in the National Rehabilitation Hospital in 2016, and its objective was to develop communication between the nurse in charge, the non-consultant hospital doctor, and the consultant on call of key patient safety issues for that shift. It was also an opportunity for collaboration between the NRH and HSE Quality Improvement Division of the HSE. So on the right here you see a template of the Daily Operational Safety Huddle. This was also a paper template of the structure and flow of the Daily Operational Safety Huddle per unit. It commences at 9:10 and it aims to finish at 9:30, but often we would go over this time. The type of information that's delivered at DOSH would include total inpatients, any patient safety instance, which would include cardiac arrest, unplanned transfers, falls, absconsion, pressure ulcers, self-harm, suicide ideation, or challenging behaviour over the last 24 hours. Staffing, which would include the percentage rostered staff on duty currently, percentage staff above tolerance level, and which unit needs to provide cover to maintain safe patient care. Patient flow would include the total number of vacant beds, any temporarily unavailable beds, any discharges or admissions over the next 12 hours, and any appointments and drives or any other business. So challenges of the current Daily Operational Safety Huddle would include attendance, making sure the right people are there. So it's usually the CNMs who attend and therapy leads from each department or unit. The reporting styles, what details to report. Only one member of staff from each unit is physically present at DOSH to represent each unit and deliver information back to their unit. Clinical nurse managers, therapists and heads of departments are away from their working area for 20 minutes with additional time to mobilise to the DOSH location. Moving to a new, bigger hospital and with new geographical footprint, this isn't always sustainable. So there's a longer distance to travel, leading to more time required to travel over to the DOSH location in the older hospital. The time to write down daily updates before attending the DOSH, usually this was performed by the clinical nurse manager. They'd have to communicate with other staff on the ward to write down on a paper template that's not standardised either across each unit to deliver back to DOSH. Voice projection, some staff members are unable to attend DOSH, therefore they have to phone in. Voices often aren't heard and information can be missed. The paper template that heads of department complete and deliver to the Daily Operational Safety Huddle each morning. The same template is read from and brought back to each unit after DOSH. Paper template isn't standardised and it's not standardised gathering or storage of data after DOSH. Often it's actually thrown out. No standardised storage of templates. Information goes missing over time as it is not used, and communication regarding patient status becomes missed or is not relayed back to staff on the units. DOSH reports are not always communicated back to the team on each unit. Staff who are not in that day will not receive feedback, therefore, from DOSH as data is not saved. Data is gathered by staff on the day of reporting to Daily Operational Safety Huddle. However, data is not saved anywhere after. Discuss then what is the purpose then of having a Daily Operational Safety Huddle if we are not saving data and calculating the rate of frequency for each unit over a period of time, as there is no statistical analysis or trends or no visual display. Live data is not available for management access over a 24-hour period, so further handovers are required throughout the day from nursing units. Nursing management mobilised each unit to retrieve handover, again on standardised paper-based template. Because we're in a bigger hospital as well, there's a longer distance to travel, so there's more time required for this. So based on the previous challenges of the Daily Operational Safety Huddle, our proposal was to digitalise the Daily Operational Safety Huddle using Microsoft Office 365 technologies and functionality that are currently available in the NRH. This enabled utilisation of a cost-effective system development. Our digital inputs required were Power BI for inputs, SharePoint for data storage, Power Automate for alerts and notification, and Power BI for analytics and reporting. Our stakeholders included the Digital DOSH system developer, which was Information Management and Technology Business Intelligence, Michael Kincaid, the Digital DOSH transformation lead and Digital DOSH content management, which was myself, Simone, Lysaght, CNM1, and Digital DOSH approval and governance providers were the Director of Nursing, Frances Campbell, and Assistant Directors of Nursing, Fiona Marsh and Valerie O'Shea, and Digital DOSH champions who provided governance of the Digital DOSH overnight included myself, CNM3's Job David and Regina Benish. And the Digital DOSH champions per unit included delegated nursing staff, which were selected by their CNMs per unit. So in order for us to move forward with a Digital DOSH system, approval was sought from the Board Executive, Nursing Management and IMNT to develop and implement a cost-effective Digital DOSH system in the NRH. Here we discussed the proposed Digital DOSH templates, outcomes and benefits of having a Digital DOSH. Continuous updates and feedback were then given to Nursing Management at weekly DOSH meetings. The Digital DOSH committee was then formed. The committee consisted of members from nursing management, nursing staff and therapy leads to discuss Digital DOSH templates and structure. This was also to provide feedback from staff units of suggested patient staffing and bed management content to be recorded in the Digital DOSH templates at committee meetings. CNM1 project lead, which was myself, then worked collaboratively with IMNT, Digital DOSH system developer Michael Kincaid and Digital DOSH committee to create a final standardised digital template of patient, staff and bed management information delivered at DOSH. Digital DOSH system development was provided by IMNT Michael Kincaid. The Digital DOSH data governance policy was written up by myself. This included effective data security and data handling policy. This was then approved by the Digital DOSH Committee and Nursing Board. The Digital DOSH governance structure was provided by myself and CNM3's Sajid Muncherry, Cynthia Lewis, Regina Benish and Job David. This was to provide 24-hour governance of the Digital DOSH to ensure timely and accurate updating of the system. CNM3's also worked night shifts, so they were able to provide night shift governance of the Digital DOSH. The Digital DOSH system management was provided by Michael Kincaid, IMNT, and Digital DOSH education providers were provided by myself, project transformation leads and CNM, and Digital DOSH champions selected from each unit. So 2 staff were selected from each unit to provide education to all staff for access and updating of the Digital DOSH. So the DOSH-going Digital outcomes included nursing management, program management and therapy leads. They will now be able to digitally record their inputs across all programs in advance of attending the Daily Operational Safety Huddle. Any delegated staff member will be able to access the Digital DOSH with their unit name and password to update the Digital DOSH over the 24-hour period. Night staff can input data into the Digital DOSH prior to DOSH. This means it's time efficient and standardised recording of data. Power BI will include live updates of the previous and current 24 hours to the system. Management will have live access to the updates throughout the day, maintaining timely responses to incidents that may have occurred or staffing issues that need resourcing. Live updates throughout the day, eliminating the need for further paper-based handovers retrieved by nursing management from each unit. This will maintain timely responses and communication regarding patient data collected. Live updates will be displayed on a projector for visual representation and to calculate weekly rate of frequency across all units. All staff will have access to a standardised viewing of Digital DOSH. This will be particularly beneficial for staff who will not be able to physically attend DOSH due to a busy unit or COVID-19 social distancing regulations at the moment. Statistics and trends will be recorded over a period of time to look back on. This is beneficial regarding incidents, staffing resources and bed management recorded per unit. So this is what the Digital DOSH system looks like. It's accessed via the NRH intranet by any PC using your unit name and passwords. So as you can see, when you access the Digital DOSH, you have your safety incident start inputs, your resourcing issues start inputs, and your bed management start inputs. Underneath, you can update or edit all 3 of these at any time during the day over a 24-hour period. So when I click into safety incidents or issues first, we have all our units here on the left hand side that are present currently in the NRH. We also have a drop down box where you can select your unit or all units. You cannot submit without selecting your unit that you wish to submit for. So if I'm submitting for any of these units, I select my unit first from the drop down box and I work my way across. So if there were any medical emergencies in the last 24 hours, I'll click yes or no. Any falls, any challenging behaviours, or any other business. If I click yes for any of these, on the safety instance issues description comes a comment box, and I can briefly elaborate on any incident that has occurred. So once I've completed and submitted my information for my own unit in patient status of the previous 24 hours, I'm then directly linked to staffing resources. Again, for staffing resources, I can only submit for my own unit. Staffing resources information includes the staff on duty is at or above tolerance level, staff have reported in sick, any agency staff on duty, any staff shortages on the unit. Now for Willow, for instance, I've clicked yes, staff shortages are on the unit. Because I've clicked yes for staff shortages on the unit, I get an extra option which is all staff shortages are covered. I've left this as no, so nursing management can have live access to this, and they can close this by providing the unit with staff. However, if they don't provide the unit with staff, this remains open, and the rate of frequency is recorded of staff shortages for that unit. Any staff expected to attend training, any appointments and drives, I can type in a comment in the comment box where the appointment is, do we require a driver. Any other business, including planned service interruptions, would involve anything to do with the environment that has caused any service interruptions. So again, once I've submitted for my resourcing, I'm then directly brought to bed management, where again I can only select my own unit and I can only submit for my own unit. So for instance, we have total inpatients, total day patients, number of vacant beds, temporarily unavailable beds, protected beds, admissions, discharges, delayed discharges, patients expected to stay for the weekend, and reasoning for vacant or temporary unavailable beds. Here we have a drop-down box where we can tick multiple selections for reasoning for vacant or temporarily unavailable beds. So this is just a sample view of the Digital DOSH dashboard per unit. The dashboard also includes all units for the NRH that will be visible via the projector in the DOSH location daily. We also have a digital patient status at a glance board, which is also interoperable with the Digital DOSH. So the type of information included in the Digital DOSH dashboard is bed management expected for the next 24 hours, inpatient occupancy, unit complexity is recorded on the patient status at a glance boards, unit occupancy, reasons for temporary unavailable beds and vacant beds, admissions and discharges, safety instances or issues in the last 24 hours, pressure ulcer grades by patient, further details or any safety instances or issues, resourcing issues, any other business including planned service interruptions and appointments and drives. And then we also have a recorded rate of frequency of the bed occupancy for the last 14 days.